physicians are sheepish. We're trained to keep our head down, to not make any noise. But at the end of the day, it's really going to take a lot of us to just put our foot down.
It's really impressive how physicians are such cowards towards other individuals that have no skin in the game.
I decided that independence for me was paramount and that I would not work for another healthcare system as an employee as long as I could help it.
My dad is a physician, my grandfather's a physician, and I could see the happiness in their face when I decided to become a doctor. I hope none of my children become physicians.
There's really a negative connotation of people saying that physicians make too much money for the amount of debt we go into and the amount of opportunity costs we have during residency. We're not paid enough.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
Work isn't your life, but it is part of it. With locum tenens, there's a way to never work weekends or to only work half of the year. You could have a job on the coast with fewer hours and more pay, or work just down the road and have a beautiful work-life balance. Create the life you want with locum tenens. Explore your options at locumstory.com. No commitments, no recruiters, just resources.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And today we do a deep dive into the business of medicine with somebody that's been in the trenches, Dr. Eric Smuklovitsky, as we say in Spanish, kind of. And he is the founder of Minimally Invasive Consultants. And we're going to go deep into the history of the business of medicine and into new paradigms of how we can still be independent and interact with hospitals and the inpatient world. So hope you guys enjoyed. This was a spicy one. Miguel might get into some legal trouble for the things he said, but that is all okay. I'll see you guys in...
Cut it out.
Hello, everyone. Welcome to another episode of the Life of Flow podcast. And I am excited about this one. We have Dr. Eric. I'm going to butcher your last name, so I'm not going to try it. And Eric is an interventional radiologist. We are, how they say in Spanish, dos alas del mismo pájaro. He's Cuban, I'm Puerto Rican, so there's a Caribbean connection there. And Eric and I met through one of the previous guests, Ronan. And we just had a conversation on the phone. He was very generous with his time. He's like, hey, bro, you're looking at these things. Let me tell you what I know. He gave me like an hour of his time. And I said, Eric, I'm sorry, we're going to have to do this again, recorded on the podcast. So here we are.
I didn't know that, but now I can say, well, I mean, his name is probably Eric Smuklovitsky.
There you go.
Español, ¿no?
Yeah.
Just
say it in Spanish.
If
you say it in Spanish, it comes a little bit easier.
It's easy, yeah.
Smuklovitsky. That's right. Well, just by you saying Eric, and I'm about to butcher this, like half the people around the country know me already knew it was me. They're like, oh, it's got to be him, because they know the name. The name is unusually memorable. Thank you for having me on. So I, as you said, we met through a mutual acquaintance, and Ronan is definitely an interesting guy, and I really like what he's doing. And so I got in touch with Ronan, and I said, dude, there's no way we don't have symbiosis. We need to talk. And so he and I have I've got to actually follow up with him, but we have an ongoing conversation in how we can kind of lump interventional radiology services into what he's doing, because I think it's very interesting.
Tell us a little bit about your story. We talked about your experience with OBLs, and then, the meat of the subject, which is how to go into business with hospitals as independent providers. So, yeah.
I think it's important to, and this is what my program director of fellowship is, to understand where we've been. You have to understand where you've been to know where you are and understand where you're going. So I'd like to talk a little bit of the history that predates us as we know medicine, because generationally, what we know right now, the three of us, is either you're employed or you become a rogue and open up an OBL, and there's very little in between, right? There are some private practice vascular surgery groups out there, but most groups are groups, but they're employed by hospitals or healthcare systems, right? And so I started out in academics out of training. I left shortly after, and then I decided that independence for me was paramount and that I would not work for another healthcare system as an employee as long as I could help it, unless I absolutely had to support my wife and kids. And so I stuck to those guns. And part of that plan was to open an OBL and an ASC, which I did with a partner. I was very fortunate in that I met someone who was already in the process of opening one. And so we he was looking for someone. It's very hard to do that on your own without someone else, especially, to have someone who's just doing cases while you're dealing with the business and so on and so forth, to kind of multiply your own ability to cover or to run a business and run a practice. So at that time I partnered with this person, and I was just all in, and the plan was for that to be the success. And what's interesting is like the Yogi Bearism is, if there's a fork in the road, take it. And at the time that we started the OBLASC, there was really a big downturn in the profitability and kind of the ability to generate revenue with OBLs really took a nosedive with CMS reimbursements and stuff. As well as we saw it was during the time where there was a lot of bad media out on these OBLs, from some of the real, hardcore profit driven ones, to I think some were more personal vendettas on doctors. I'm really not sure. I don't want to, those are not my opinions. It's just the scuttlebutt. But what I saw during that time is right when my OBL started to pick up and my referrals were becoming more consistent, as I just saw a complete drop off in all those referrals. So it was just very hard to survive. And using the knowledge I gained in the OBLASC setting, it helped me understand how is that relevant to an inpatient, or what the impact an interventionalist or a vascular specialist can make in a healthcare setting or a hospital, and especially in an inpatient setting or hospital outpatient setting, because we all know that the billing there, the billables, the account receivables are just astronomical compared to OBL or ASC. So, as I said, when there's a fork in the road, take it. I was presented with an opportunity to take over a professional service agreement for a hospital, and so I did that with who is now my partner. His name's Brian. He's a wonderful guy. He's one of the best guys I've ever worked with. And here we are, and it's working. And so, kind of get the word out. Ideally, I'd love for people to ultimately join me. I'd love to have a multi-specialty group, with vascular surgery, cardiology, interventional radiology, and vascular medicine doing this eventually. But so to go to the history to understand where we've been, to know where we're going, is if we dial back the clock 20, 30 years, or even before that, physicians, you got out of medical school, you did your residency, maybe you did a fellowship, and then you started to practice. And oftentimes you would go get a business loan to purchase an office space, and you'd have some kind of business loan to be able to pay salaries to front office staff, a nurse, maybe a couple MAs, to room patients and whatnot. And then you'd go to the local hospital or hospitals and then get on staff. So you'd apply for privileges, and then you would just be on call all the time. And that's how you got your patients, is the ER would call you. And depending on the market, whether how saturated it was or how aggressive other physicians were, generally speaking, there was always going to be some older docs that didn't want to take as much call. So the new doc establishing their practice would just take all the call. And that's how you got your patients. The ERs would call you for consults, right? And then you do a good job, you build your patient charts up, you build your practice, and then you start getting referrals from internists. Maybe you did some physician to physician marketing. Maybe you were the vascular surgeon on call, you got called. So you made a courtesy call to the patient's primary care. Hey, I have your patient here and whatnot. And that's how you start a relationship. And that's how you build a practice. But the way that you generated revenue, was by physician fees. So when you look, a very good thing to do is when you're looking at becoming independent or opening an OBL, I'm sure that both of you have done it, is you search the procedure, CPT. I'll search the name of the procedure, I'll put CPT, and then I'll put reimbursement. And usually it's the medical device companies that will put out a nice PDF of what the CMS averages are, and they update it every year. And you'll see the breakdown of physician facility, physician non-facility. So usually physician non-facility is what you'll see in an OBL. And then you'll see facility fee, whether that's ASC, hospital outpatient, and then hospital inpatient. It'll either give you what the dollar amount is for CMS, or it'll kind of give you a DRG code, because it's a diagnostic related group. So there you'll have to look a little more. But when you look at these physician facility fees, so essentially that's what the physician gets paid if you do a surgery in a hospital. Those fees are $100, couple $100, $800. It's not a lot of money when you really look at the fact that, okay, this surgery or this procedure is going to take me 4 hours, right? But those physician fees used to be, let's say, thousands of dollars, right? And I don't want to misrepresent, it was thousands of dollars and physicians were gajillionaires because of, one thing I'm very careful about is that there's really a negative connotation of people saying that physicians don't you make too much money. And I vehemently disagree with that for the amount of debt we go into and the amount of opportunity costs we have during residency being paid just above the poverty line. We're not paid enough. And so when you go back to what it was.
And also I would add to that the incredibly high cost of operating.
Exactly. Incredibly
a business.
high.
The overhead. I've never really contextualized it until now in this phase of my life where I built a practice from the ground up, but it's front intake, communication, answering services, staff to manage clinic, manage cases, products, and then RCM, claims, denial management, credentialing with insurances. Like, that is so retardedly expensive to manage that. Yes, there's a lot of money swinging into the account, but I've never written so many big checks in my life. Like when I'm like, oh, here goes $70,000 out. Like you're like, oh shit, I got a great claim paid today. And then that same day you're writing a check for $100,000 that you owe a company and products. So there is a super misconception of what that means.
A very big misconception.
What I would say to clarify is I do believe that those physician payments change depending on what geography you are in. And there are certain areas where the vascular care is scant and or inexistent to a certain degree. And those places pay much better. So like if you were to go to Puerto Rico right now, right, Lucas, you know this well, those physician fees
you're not paying more. No, not in Puerto Rico.
They're paying a little more, no?
Less.
The physician fee, isn't it more in areas that are underserved?
I think it's a matter of economy of scale.
But not Puerto Rico.
Not Puerto Rico.
Yeah.
Okay.
Yeah.
So let's just do some rough math. And so as Miguel, that brings me to a really good point here is, let's say you're paid $1,000 physician fee per surgery, right? And so this is just what the physician collects. So let's say a fempop bypass, you go in and you do it, and you are an independent physician. So mind you, we were back 30 years ago. And let's say you can do 5 of those a day. And so then that's 5,000. Let's say you operate 4 days a week. So that's 5,000 a day times 4. That's 20,000. Let's say you take 10 weeks of vacation. So you're doing 5 of those 4 days a week. And then you're going to times that by 42 weeks. See, that's a revenue of 840,000, right? And so then what we do is add on all of your E&M, right? So your rounding, your consults, your office visits, which, is not much, but let's say that your total revenue as a vascular surgeon now is, let's just put it at $1 million for rough numbers, right? But as you said, then you have to pay your office lease, right? Let's say you bought it or a mortgage because you bought your office space or you leased it. You have to pay your office staff. You have to pay your medical malpractice. You have to pay revenue cycle management. As you mentioned, RCM is a billing company to do your billing for you. And, let's say there's some attorney's fees in there or whatnot. And so in reality, your take home is more like 300, 400,000. But at that time, you're independent, right? And you have your own business. You have certain write-offs that you're not a W-2 employee. And that's just how medicine was. I mean, being employed just wasn't even a concept. The reason that this is important to understand is because you had the right to admit your patients or schedule your procedures in the hospital that you wanted. And that's what gave physicians control. And that's what gave physicians autonomy, because you were not a captive audience. So if a hospital was doing something you didn't like, or stocking some gear that is way cheaper and not as, is an inferior quality to what you want for your patients, you say, okay, then I'm not bringing it to your hospital. I'm going to go to St. Elsewhere because they're going to stock the equipment that I want. And all of a sudden that hospital is going to get the revenue, right? So for the $1,000 physician fee on the fempop bypass, let's say the hospital is billing, 50,000 for that surgery. So the facility fee is way bigger. And what happened is in the I want to say the late 90s, early 2000s is when we really started to see physician fees dropping and facility fees going up. And physicians, it was impossible for them to survive. The revenue just wasn't there for them to pay for an office, pay for office staff, pay a revenue cycle management company, pay for their own malpractice. And that's where we saw a lot of physicians selling their practices and becoming employed by hospitals or healthcare systems, because it was just a survival thing. The numbers just weren't adding up. But what happened there was we gave up our autonomy, because once we became employed, the hospitals had, to an extent, an ability to tell us what to do and how to do it. But I'll give you an example. Have either of you, I'm sure anyone listening to this podcast, have worked in a hospital where there's a physician lounge with free drinks, free food, or free coffee, and it could be anywhere from something that's very modest to some that are actually pretty elaborate. Do you know the history? Of that, or why those exist still? And so those are a remnant or a custom of, in the past, hospitals would have these elaborate physician lounges and lunches to attract physicians to admit their patients at that hospital. Because if you say you're an internist, you have your clinic in the morning, you go around on your patients during lunchtime. If you remember, doctors' offices would close for about 2 hours, right? And so you go around on your patients and you have this wonderful lunch free of charge. And then you go back to your office, see your patients in the afternoon, and go home. And so I remember going to have lunch with my dad, and the first time I had duck or rabbit was in a hospital, because this hospital had a French gourmet chef, and they would have white linen tablecloths with waiters that would bring you lunch and everything. And it was all about just attracting physicians, or making the hospital environment pleasant for the physician to bring their patients there, right? And
Those were the days, brother.
those were the days, brother. Those were the days. So these hospitals that still operate physician lounge, it's a nice little perk, but it's more of a custom of the old days, where they were just trying to make a very nice environment to entice or incentivize physicians to bring their patients there.
The hospital where Lucas, you've been there, but Eric, you don't know. But I office in a building that used to be a hospital at some point in the past. It was called University Medical Center. And one of the coolest things about UMC back in the days of glory was that there was a chef on site with a massive hibachi. So you would literally walk in and be like, I want a tenderloin with and the dude would be there from 11 to 1 cooking whatever you wanted, a pasta or fresh whatever, and they would just scoop up, and the chef would just build, and that place is still there. Is now this obviously cemetery of memories, but the whole hibachi thing is there. So you could go down and just be like, man, this had to have been so cool. I never lived that, but it had to have been so cool to go and do your cases, or going around and then go to your chef, and it'd be like, dude, I want a filet mignon with some mushrooms and a beautiful bechamel sauce. And the dude just whip it up for you. And then you just have the view of the Met Center in the back. It's still there, man. Next time you're in town, I'll take you, Lucas, because it's a good graveyard of what the good times were like.
And those were the times of, I'm betting, Cooley and DeBakey, and a really good book to read
A little bit after that.
A little bit after,
but yeah, a little bit after that. It wasn't that long ago, really. It was 15 years ago, 20 years ago, where it was still a thing.
Yeah. Well, they don't have to do it anymore. They don't have to hospitals don't have to create an environment to attract physicians and bringing their patients there, because they don't see it as the physician's patients, it's the healthcare system's patients, right? And so in becoming employed, physicians gave up a lot of autonomy. And I think that a very myopic way to look at it is, oh well, their generation screwed it up for the rest of us. And you could say that, and they did, but they also did it. I mean, they just didn't have a choice. I mean, this was survival. The physician fees just took a nosedive, and they just had no other way. And the hospitals legally cannot share that revenue with physicians. It goes against Stark law. So there are federal laws against this, and so it would make perfect sense that, like, hey, if I bring all my surgeries to your hospital, throw me 10%.
Guys, we've talked about this ad nauseum in this podcast. Hospital political torque at the Hill, the lobbying energy and power of hospital associations is some of the darkest, heaviest things in the world. And they've been behind these massive uh uh what would you say, like deflating, let's say deflating exercises. One, RVUs. Fuck that, Ross Perot and your bullshit. RVUs, fuck that. Two, physicians can't own hospitals. Fuck that too. Like, why? Like, a guy with criminal records can own a hospital, but we can't. Like, but if he's a, if he's a if he's a elevator repair guy that's been in jail before, he can own a hospital, but we can't because we're crooks inherently. So this is what they've done. So then you made the RVUs, you killed the system, you don't let us own, and you went to the Hill and you said, guys, you're spending too much money on doctors. You have to drop their rates, and we have to kill the rates so that we kill the independent physician, and then everybody migrates into the hospital. And now, the last of those is like, we're not going to give them lunch, right? But that's like the tail end of this, I feel, systematic approach to just absolutely fuck physicians.
Yep. No, I agree. I agree. And to an extent, we allowed it, in the age of the giants that actually had political influence and had power. Somehow it just happened underneath their noses. And, because it used to be that doctors could just call their local senator and just say, hey, man, you know, or call the mayor. Hey, I got a ticket. Don't worry, we'll take care of it. But they just let it happen. And again, I don't want to be too accusatory of a generation, but something bad happened and they gave it up some way or another, whether by just being absent-minded, being apathetic, I'm not sure, but something occurred that, yes, and the lobbying power of the hospitals and healthcare systems is such that we it's I mean, how many generations is it going to take for us to catch up, right? And now you look at the physician shortage, we're even lower in numbers and lower in money, that I don't know that we're ever going to catch up. But I think that we're in a very interesting pivotal time with the physician shortage, that we can flip the script back into having control again, right? And we just need to play the game. We need to play the game, play it, play the ball as it stands, right? And we'll get into that a little bit, but part of it, I agree with you. I don't know.
I don't know that we had the least amount of applicants in the history to medical school in the last year. Who wants to do this? Plus, you have AI coming in, which is going to fuck everybody over. So now it's like, okay, debt up the wazoo, AI trying to threaten your specialty or your art, hours like crazy, no work-life balance, to be sucked into a system that doesn't care, that makes you a liability and not an asset. Uh, it's gonna take a lot of us banding together and figuring out how to make a better future, because otherwise I think we're in real trouble here.
We've got to grow a pair, and we've got to really, be courageous. And I think it's going to take some physician leaders to do this, and it's also going to just take courage of the people to follow those individuals. But as one of my partners says, physicians are sheepish. They're smart sheep, but they're sheep, and we're trained to keep our head down, to not make any noise, and not, but at the end of the day, it's really going to take the lot of us to just put our foot down. And as my dad is always says, the most powerful language, the most powerful word in the spoken language is no. And just say no.
It's really impressive how like physicians are such sheep, and I'm gonna say cowards, like cowards towards other individuals that have no skin in the game, so it's really impressive. And I found myself there. And when I went into it, I was there's some inspiration from people that were like, cowboys, that just bucked the system, that made things happen. um and that was the inspiration. But then would you get to the other end of it, and your community is, and you're part of it, you're part of the problem, is not up to par. So we get to be a little bit, that's a little bit what we're doing here. We're trying
But
to
I'll
create a
tell you
little
the I'll
trouble.
tell you the playbook. I'll tell you the
Yeah.
playbook. I'll tell you the
Yeah.
playbook is going to be the same. They're going to, now the hospitals are happy there's less doctors. You know why? Because now they're going to go out, probably not in this administration, but in the next 10 years, they're going to make it super easy for international medical graduates to just pour into the system, who are going to be happy to come
Yeah.
and work for peanuts.
Yeah.
And like they're going to be just workforce, right? I'm going to bring in 20 new physicians from Africa. And I'm not trying to be insulting. I'm an international medical graduate, guys, but the quality of IMGs that you're going to get when we were fighting against Stanford and Harvard guys to try to get a position versus the ones that are going to come in because we just don't have any hospitalists to cover these hospitals because there's just no more bodies. It's going to happen before AI takes over. You're going to have an influx of that. And then there's going to have to be a radical bounce back.
Yeah, there's a strong political force, and it's painted as extreme right that is fighting against that. And I think in the media paints it as like extreme right, both in Europe and in the US. But we're not the only ones that are suffering this. Like workers across the entire market are seen as coders, like people in tech. One of the reasons that they this whole H-1B visa thing came up, and like Elon and the administration were like in opposite sides, is because they bring coders from India, and they're like, oh, like we don't have coders here in the US. Well, that's fine, bring them, but pay them the same, so you don't lower all of our salaries, because if you pay them less, all of our salaries go down because the market prices that in. So yes, that could happen, but just know that there's a lot of people that have a sentiment against that, for sure.
I could tell you, I know physicians that have reached out to me who are internationally recognized key opinion leaders that call me and they said, "Hey, I heard there's a there's a little path to get into the Texas Medical Board." And whatever, I don't know. They asked me as if I knew. I was like, "Dude, I don't know anything." But then and out of curiosity, I will just say, "Okay, well, let's say that I could bring you up. What would be your expectation from a salary position?" It's like, "Well, I've been doing this for 30 years." "Yeah, man, I know how fucking good you are." "Well, how much would it be?" It's like, "Well, I don't know, like $250,000. I'm like, "You don't even know that if you do get the opportunity, you should be able to at least say 700,000 or 800,000. But think about a guy that's that high in the scale of quality internationally, ready to come to America for $250,000. That just throws a wrench into the entire system.
Well, no, they're all going to come here, But when you look too, I mean, there's excellent physicians all around the world, but there's a reason why the richest of the rich that have the ability to do so come to America for treatment, is because the American medicine is better. It is. We don't have a perfect system. You could argue that it's a broken system, but at the end of the day, the best treatments are here. Period. End of story. And when you commoditize medicine, you eliminate competition, you eliminate attracting the best of the best, because let's face it, we enter into competitive spaces because there's an ability to advance yourself, both professionally, economically, you name it. But look, we all went into this to help people, but I think there's a lot of us, if there wasn't a prospect of a comfortable life or wealth or something, a lot of us would be looking at doing something else, because who the hell would go through 10 to 20 years of schooling and training and all that, as you said, sacrifice, no limits on hours, no work-life balance, to then just go make a little bit of money? It's not worth it. I would tell anyone this. I would just say it's not worth it if it's going to be that.
Well, I'll go as far as saying I hope none of my children become physicians, which is sad because my dad is a physician, my grandfather's a physician, and I could see the happiness in their face seeing them when I decided to become a doctor. The pride and the energy and the aura emanating from my dad was amazing. And right now, I would be absolutely depressed and distraught if Lucas would come up to
Why?
me and say, "Dad, I want to be a doctor," because of this shit that we're in,
But
man.
you have a
It's
what do
not
you
fun.
create? Okay, so you've struggled for 4 years, and you're coming out, and then in 5 years, you could have a thriving practice that is how you
Potentially,
wanted
but
to.
I want him to be a coding bro, man. There's much easier ways to live life and create wealth. This one, bro. Every day we go out the door, we're putting our lives at risk. Nobody cares. Where patients are not. I mean, this is not generalizing, but dude, it's hard. The complaints every day that you're not answering appropriately your phone calls, the Google reviews that they leave because nobody sits up for a fucking good Google review, but you take 2 hours to write a shit review to make you look like shit. Um, the medical malpractice, being under the gun, every single decision you take makes you be very fucking afraid of taking maybe some leap of faith and a moonshot to get somebody. You just give up. You're like, hey, no, we can't do anything for you. That's it. I mean, because at the moment that you push maybe outside of the boundaries of what the fucking society says of vascular surgery, then you're gonna have three motherfuckers that are gonna look at you and gonna go to the stand and say, no, I don't know what this deep venous arterialization shit is. It's not in any book that I ever read. So it's like it's not fun, man. They don't pay well. It's super boring. It's super aggressive. It's super litigious. What the fuck about I'll say this. If my son says, Dad, I want to be a doctor. I want to surf. I want to take care of sloths. And I want to live in Costa Rica, a very low, income and happy because I love taking care of patients and the social security. And I'm going to live on $5,000 a month. I'd be like, I love it. Let's go. I'll actually join you in your practice.
Yeah.
I mean, when you add it
glamp
all up,
for the rest of it.
yeah. When you add it all up, I mean, it's
It's not fun unless we do something to change
we have to
how we're doing things. We are really fucked.
Oh yeah, I agree.
And people are fucked because guess what? If you don't have us, you're gonna fuck.
Oh yeah, no, the public, definitely the public stands to suffer immensely if physicians just either we're not producing or creating enough physicians, and then the physicians we have just walk away because the environment is such that it's primed to just walk away and go do something else, and especially these days with you can do e-commerce, you can do social media, there's all kinds of ways to make money that, you're not just pigeonholed into medicine, you can just do something different and forget about it. Believe me, I've thought about it. So um, I think as physicians, you could even make it righteous and say, in order to advocate for our patients and advocate for our, the future of healthcare, which means helping people, not profits, and not, controlling the market and capping physicians and all this, is that we band together. And I think that we are in a pivotal time in medicine that if we can educate ourselves on the business and how things work and how the money moves around, we can play the game essentially. And we can be angry at how things are all day long, or we can just sit and say, this
Like
is what we
me.
got. Yeah. No, you're fine.
Yeah,
You're in a
We
you're in
could
a
be
very
like
hard
Miguel.
time.
yeah.
You're in a
I
very hard time. I know where you are right now, and that is not a those are,
I like the
I
idea
refer
of
to
playing
those
the
as dark
game.
ages for me. Yeah, no, we got to play it where the ball stands. It's on Frankenstein's foot, right? Like in Happy Gilmore, you got to play it.
Yeah. So let's talk about physician service agreements,
Yeah.
and how how to
Yeah.
come about one. Yeah.
Your OBL thing took a dive.
Yeah.
But now you're in a good place. Or in a better place.
We're doing good, and we're in a situation
Okay.
where all parties are benefiting. But yeah, continue, please. And then
So no. So I would love to. I love that we're fucking with your notes, by the way. I love that you're like scrambling to try to keep your notes, and we're making you jump all over them.
Yeah, all over
I
the
was
place.
like, I hope that at the end you're like, I should have not done any notes because these fuckers didn't even let me follow my
No,
cue.
no, it's all good because there's just some important little points and nuances that I wanted to make sure I covered, like, the history and kind of independent physicians and the thing about the physician lounges and the gourmet food is just to kind of set the scene so people can really wrap their idea around because it's such a foreign concept that, wait a minute, hospitals cater to physicians to attract
None
them.
of the kids now know that.
No, they
None
don't.
of these
They
kids
don't.
know that.
They don't.
And they'll
and
never
this
know that.
This is why we need guests with structure, Miguel.
Yeah. And Miguel, to your point, I've had some senior physicians call me out as, and if I'm invited to be on a committee, I'll do it if it's relevant or if I think, but I'm not going to just join every committee that I'm asked to be on and be part. And I've had a senior physician call me out and say, well, your generation, you guys won't do anything and yada yada. And I said, let me tell you what, your generation, you guys used to have political influence. You guys used to have a place in society. You guys would amass an incredible amount of wealth and retire rich and have generational wealth. We don't get any of that. So this whole thing of I'm going to be self-sacrificial, I'm never going to be home, my marriage is going to fall apart or I hardly see my kids, but guess what? All their college is paid for, they have inheritances, all this stuff. I was like, we don't get any of that. So don't come to me and call me out on this shit that you guys don't do enough or you guys don't care. Because really the whole thing is flipped on its head and we just don't get in return what physicians once got, which, like I said, it was wealth, riches, power, political influence. A guy like Cooley or DeBakey, you know, they probably had dinner with the governor of Texas, once a year or something like that, or I remember even my dad going to a restaurant and saying, "Oh, I'm so sorry. Look, we're late, and I think we had a reservation. Oh, you're a physician. Don't worry about it. Well, here we got a table for you right here." And now, you try to do that, and you're like, "What are you? You're a physician?" All they care about is, the Instagram models and the, reality TV people and finance. And so, you know, and again, it's not to be bitter about it, but it's a balance of things of, I'm not gonna, yeah, our generation is more work-life balance focused. And the fact of the matter is if we weren't that, it's just not worth it anymore.
The restaurant probably is like, no, we only take high earning individuals.
Exactly. Yeah, exactly. But it's a different world now. And back to physician fees went down, hospital fees went up, you know, that became the era of hospitals and healthcare systems holding the cards. They held them, and that's just what it is. At the same time, corporate America entered the space, right? So that's where we saw for-profit hospitals. So Tenet Hospital was one that started in Florida, HCA, and the hospitals became this thing that instead of being geared towards having an environment that was conducive to physicians bringing patients, which meant more business and then meant profitability, it just turned into we own the game. We are the controllers of the game, and let's how do we turn profits, right? And that's where you start hearing the horror stories of cutting staff, not having proper equipment, so on and so forth. And things aren't so bad, but there's it's some version of that today. But everything in medicine runs about a 10 to 15 year cycle, and that's one of the points I have here. And that was something that I learned from my dad, because I always remember as a kid, he'd come home, be talking to my mom kind of about the things that were going on in the group and the meetings they were having. And as I remember at one point I was old enough to understand that the conversation sounded really dismal. And I asked him, I said, "Dad, are we going to be okay?" And he says, "It's always the end of the world." And that's what a lot of people start to beat that drum, is that it's the end of the world because this big change has come. But things just change and we figure out a way and we keep going. And that was probably around the time of one of the big physician fee cuts to radiology, right? So when those seismic changes occur, whether it's a CMS schedule change or whatever it always hurts us in the short term, but then we figure out a way. And then that brings me to OBL ASCs, is that I think OBLs ran a good 10 to 15 year cycle of being a very good model to get away from being employed and bring back some independence. And it's a huge responsibility, it's a huge financial risk. But as we know, around the country, there are there's a good fair amount of surgeons and interventionalists, whether cardiology or radiology, that are doing well at it, right? I do fear that it is at the end of its cycle because we are at the 10 to 15 year mark. And as I got into it and things started to kind of look like they're taking off and then it took a nosedive, I do think that instead of continuing to dive, it's starting to come up, because this year we did see an increase in CMS reimbursement for OBLs. But then the natural progression is, because it's a balanced budget, when CMS looks at utilization, they're going to lower the reimbursement of they're going to lower the reimbursement on the high utilization CPTs. And then eventually what they'll do is, in the case of OBL stuff, and so we can take dialysis access management, so all the dialysis circuit codes, there was a lot of abuse or a lot of utilization, I'll say, maybe some of it was abuse. But when they started to balance the budget on that, what they did was they started to decrease OBL, or physician facility, uh, fee schedules, or fees on that. And then they started to increase ASC. And the reason is because ASCs are a lot harder to have. So you create a selection bias of there's just not going to be many out there compared to OBLs. And then once it's on the ASC side, then what they do is they bundle it. So you see funny things in the ASC, such as if you do a, I don't know, 37O something, which is a peripheral, arteriovenous circuit angiogram with peripheral angioplasty. The additional code for central venous angioplasty is $0. So you don't even get paid for putting a balloon on the centrals in an ASC. And so that's kind of the bundling that we see. And then once you reach that point, it's pretty much commoditized, and it's very hard for anyone to really turn a profit at it unless you're doing huge volumes. Okay. So I think there will be a place for OBLs no matter what, and they won't go away. It's always going to be hard to turn a profit and to make a living. But, for those who choose to do it, if it's worth it to you and have that independence, then it's worth it. And, it was great. I loved that environment. I love the fact that, like, I was my staff's direct supervisor. That was always nice. And, operating in that OBL was the best thing ever, because it was smooth, it was fun, it was beautiful. But again, moving back towards the inpatient space, I think that we as physicians, with the shortage before all these impending changes that could happen, we can band together and kind of negotiate physician service agreements that are compatible with what we should be earning or what we are happy earning, as well as maintaining our independence, because then as independent physicians, they can't tell us what to do. We're not employees. And it's a good way of keeping the system honest, keeping us honest, and it increases physician availability to the patient, so the patients benefit. You have physicians that are hopefully educating themselves on the business of things, that can run more profitable departments within a hospital setting. And then so the healthcare system sees more profit. And so really everyone benefits. And my partner and I, what we do is what we essentially do is bring OBL efficiency. As we all know, the margins in OBLs are razor thin, right? So you got to be super efficient with your equipment. You got to be super efficient with your time. Make sure you're not loading up the back table with a bunch of wires and different balloons, and just kind of have a plan, go in there. Because if you burn a bunch of wires and balloons and stuff on a case, then there goes your margin, right? And you can't have a business that doesn't make money.
So what's the negotiation? Explain to me, if I were to say, fuck it, I'm going to sell an amputation prevention center idea to the hospital, and I somehow convince the vascular surgeons at the hospital that I'm just going to take all the legs off of their hands, which sounds incredibly complicated. But let's say that they would agree. They're like, yeah, we want to focus on anything else that's not legs. You're going to take the legs. You're going to build a business within the hospital, and you're going to have an independent practice with what is the negotiation? What is it? A capitated model of care? Is it just a base salary and then you bill for HOPD rates since you're in the hospital? Who has the contracts? who runs the money. It sounds to me very convoluted. So, but maybe if you can dissect it.
Yeah, sure. So basically, you just got to use everything that the hospital has to your advantage, and not in a deceiving way. It's more of just saying, hey, I'm going to be here. We're going to have a service agreement. You're going to bill everything in my name. You're going to keep, so the hospital will do the global billing. The hospital, the healthcare system will keep that.
So you have to be accredited through the hospital's contracts and the hospital physician organization.
Exactly. But it's actually great because you eliminate that cost to you as a business, right? Of having a revenue cycle management company
But you're not an
you with it.
employee. You're not an employee. You don't get paid by them.
No, and then eliminate, RVU. I hate it when someone's like, "Oh, I did this case. It's 50 RVUs." I'm like, dude, what's the number? Like, what amount of money did you produce for the hospital? Yeah, RVUs are designed to just keep us in the dark and not understand. It's monopoly money that they have us playing with, right?
So how do you do price discovery for your worth? Because obviously your worth is not, at that point, is not just the physician fee, because the concept is physicians fees are going down, hospital fees are going up, but really the whole value part, or a lot of that value, obviously there's value in nursing care and like ancillary services, but a big chunk of that value that's way higher than the physician fee is being brought by the physician. So how do you do price discovery on the whole?
What you can so under No Surprise Billing Act, you can request everything that's billed under your name. And then by law, the healthcare system cannot keep that from you. So you can ask for those billables, right? So we should probably discuss how does billing work, right? And what is the money? So we talked about CMS fee schedules. For those listening to the podcast, hopefully you've already looked at it, or you're looking at it right now, or you're going to look at it. But I think the number in our head, if we look at a below knee or an SFA angioplasty stent with atherectomy, I think the number in all our heads is about 10 to 12,000, maybe around 11,000 for CMS fee schedule. So that's what Medicare pays, right? That is the Medicare average, and there's no negotiating with Medicare. So if you open up an OBL or a hospital and you are going to see only Medicare patients, that is what you're going to get, period, end of story. And that fee will do this depending on what the CMS fee schedule is year to year, correct? The interesting thing comes in with commercial payers, and Lucas, to your point, how do you find out what that number is? How do you find out what that value is? And it's a number of things, whether sometimes I've had patients just share their bill with me, right? And then there you can see the itemized things, and then you're just like, oh my God, this is astronomical. I could probably pull up something. I mean, I think they were charging like $5,000 per coil or something like that on an embolization I did, and then I reached out to my rep, hey, what's the contract on the coils, and then, the coils are $800 a pop. And so they're making, buku bucks of profit on per itemized expendable in the procedure. So there's all kinds of ways. So one way is No Surprise Billing Act. You can request what's been billed in your name. Okay. The fact of the matter is that healthcare systems have a charge list, and that's the dirty little black book they don't want anyone to see. So another thing in our VATS committee is that we've asked that we sign non-disclosure agreements. And if you sign an NDA, then you really got to keep it quiet and not tell anyone. But to sign an NDA to just see what the charge list is, because they have this stupid thing where finance green lights or red lights a device, and they'll red light something, and then we'll all say, my partner and I will. And most people in the VATS committee don't know the economics like he and I do, but we'll say, no, that's BS. They're wrong, because this is a very profitable procedure. But going back to commercial payers and charge lists, essentially we all talk about OBLs and, oh, this person got a good contract. They're 2.5x of CMS, or, in a very saturated market, probably Miguel in Houston, you're seeing 80% of CMSs, or, if you're lucky to get 100%. I mean, certainly in South Florida, you're lucky if you get 80% of CMS. And so if that procedure pays $10,000 for Medicare, and then you have a patient Blue Cross or Shield, you're going to get paid $8,000 because you're 80% of that, right? Whereas in a less saturated market, as an OBL, you'll have 2.5x of CMS, and so you'll get $25,000 as opposed to $10,000 if it's, and again, Blue Cross Blue Shield or United Health, right? So I think a lot of the commercial payers have figured out that even in an underserved market, that they don't have to pay a multiple of CMS, that they can still just kind of have you at 100% CMS. And that was one of the big reasons why I wanted to get out of my outpatient practice, is because all of our contracts were 100% of CMS. And so a lot of people would be very happy with that in a lot of markets. But in our market, we were essentially the first OBL to the area, period, end of story. And there was no reason we shouldn't have been getting 2 or 3x of CMS to maximize what are the revenue we could generate per procedure. And at that rate, if you are charging 3x of CMS to a commercial payer, you're actually still saving them money compared to if that patient were to have that same procedure at a hospital.
That's what I don't understand. That's where I see our saving grace, is if we're able, as we're trying to take on the hospitals, if we're able to say to the CEO of BCBS and Cigna, well, no, hey, sit your ass down. I'm gonna do the same procedure. I'm gonna use less material. I'm probably gonna get you better results than if it goes to the random dude that never does a leg. And it costs more at the hospital. It costs you 350% more at the hospital than it costs here. Why would you not give me 110, 120% of Medicare rates? Like, why aren't you doing that to try to drive the business? It's what makes me think that there is a little bit of glimmer of hope, and hence the reason why the OBLs got a little bit of profitability this year, because maybe through OEIS and entities like that, appropriately organized scientific societies that care about physicians, they're actually sitting down with some of these guys and saying, hey, this is in your best financial interest as, as an institution that pays for healthcare. Why don't you send the patient to me?
I agree with you 100%. And your OBL operators, let's face it, tend to be your higher skilled operators, because let's face it, you need to be good to be able to do that at an outpatient setting and not have to admit a patient after and get them home the same day and so on and so forth, and not have an admission afterward. And if I were CEO of an insurance company, that would be on all the vascular side. That would be one of my first orders of business, is seeking out every local market. Who are my OBLs? Who are the top operators? Like, who are the real limb salvagers, right? And let's give these people good contracts. Let's incentivize patients, because when patients, they can go on their insurance portal, it'll tell you where you can go. It'll even tell you, like, I don't know if it'll tell you your copay, but you could say no copay if you go here, to incentivize patients to choose, because at the end of the day, they can choose where they want to go in network, right?
I think that's illegal, though. Allegedly, some facilities, what they do is they say, listen, you're going to get a bill, but throw it in the garbage. But you cannot not bill. Like, it is an absolute, you have to bill.
Yeah, you as the physician have to bill, but if you look at your insurance, you're just like there, or you could be a preferred provider. I don't, let me not speak out of place. That's actually not, I'm not 100% on that, but the insurance companies can find a way to shunt patients or incentivize or get them to you over going to a hospital, right? So when a hospital contracts, I hear a lot of people when they talk about what a hospital charges or what a hospital's contract is that they'll say, oh, yeah, hospitals get like 3.5x, 5x of CMS. They're not, the hospitals don't operate on a multiple of CMS. So CMS is irrelevant to what their charge list is. And so their dirty little black book is, if you look, if anyone listening on the podcast has ever received medical services and has insurance, you'll get a bill. You won't get a bill. You will get a summary of benefits in the mail for every medical encounter you have. And when you look at that and look at the itemized list, so let's say for us, you're young, your wives were in the hospital for giving birth, right? That's where a box of tissues you'll see is $300, right? You'll see that my wife, they tried to give her some solution. I think it was like simethicone with magnesium, something, that they give every woman coming in for labor. And she says, no, I don't want to take it. And they charged us for it. And so that was one of the items she argued on the bill, because that little solution of simethicone, magnesium, whatever it was like $400 or something like that. And so, and the point is not that, oh, they charge, that was just a mistake. They didn't take it off the bill. So she called and they took it off. But the point is, like, there's no way that little thing actually costs $400, right? But that is the charge list of the hospital. So they have this little black book where they decide, okay, this is how much this is going to cost. So a gallbladder, a routine laparoscopic cholecystectomy, excuse me, let's say it's $100,000, right? But then you go to the CMS average fee schedule for what a lap chole is. Let's say it's more like 10,000. And again, these aren't real numbers. So when St. Elsewhere negotiates with Blue Cross Blue Shield and they say, all right, let's have a service agreement. And so when you are in network with an insurance, it's because you have a service agreement with Blue Cross Blue Shield. So when a patient comes to you, whether you're a hospital, a physician, a doctor's office, there is a predetermined amount of what that service will cost to the commercial payer. Okay. And so back to your summary of benefits. So I remember my wife's my after our first kid, my wife's bill came in, and let's say it was like $80,000, right? And then it said Blue Cross Blue Shield paid 20 something thousand. You know, it's always like it's never an even clean number, but it was like 20 something thousand. I'm like, oh my God, am I about to be held responsible for the other 50 something thousand here? What's going on? And it says you are so the bill was say 80 something thousand, Blue Cross Blue Shield paid 20 something thousand, and it says you're responsible for $1,000. I'm like, wait, what? And so the difference in that number there is what the hospital charged was 80,000, but what's behind that discrepancy is that the service agreement is a discounted number from the charge list. So again, let's say St. Elsewhere and Blue Cross Blue Shield sit down to negotiate a service agreement, and the hospital puts a piece of paper down. They say, okay, here's, this is what we charge for these services. And Blue Cross Blue Shield's gonna say $100,000 for a lap chole. No freaking way. We'll give you CMS. And then they say, no, we're not going to accept that. And there'll be a back and forth, but they'll agree on, say, like a 60% discount or 65% discount on the lap chole. So instead of $100,000, they're going to pay $35,000 for the lap chole, right? And then the CMS average is 10-15,000. And so the commercial payer will generally accept paying more than CMS, but then that's how you hear why someone will say, oh yeah, the hospitals collect about 3x of CMS. Does that make sense? So the number may sound or may seem like a multiple of CMS, but the actual contractual agreement between commercial payer and hospital or healthcare system is not a multiple of CMS. It's the hospital has a charge list. They determine what that number is. It can be incredibly overinflated, but then they will give a percentage discount to the commercial payer on that charge list. So that's why when it's out of network, the commercial payers, they get charged up the wazoo, and then that's why your out-of-pocket maximums and your copays go up, because it's exorbitantly expensive for you to go to a healthcare system or hospital outside of the network of your insurance, right? So that's where, and then the hospitals will love that because legally they can bill, right? And they will collect that money.
The money bag is you open a hospital, you have an ED, you get no contracts. You're completely out of contract, out of network with everybody. And patients come through the ED, they're on the hook. And when they pay them some marginal amount based on what their network rate is, then that hospital administration takes them to a thing called IDR, which is a federal process of review and dispute. And 95% of the time, it actually goes towards the hospital, as long as the hospital shows that magnesium shot is $500, that the blankets and the box of tissue was $600. They can't really dispute that on, and the company ends paying for it. So I've thought about this long and hard, and I know that we're running out of time, but I've thought about it. What if if I could create some sort of ED designation, allow walk-ins, drop all my contracts, and take care of people with actual wounds, and then just charge them and then take them to IDR. So because CLTI is an emergency. I mean, it's a diagnosis that they get through the ED and they have to. Why, when they come to my office, because I'm a site of Service 11, I can't do that. I have to be in network. So could there be a possibility? Well, is that better? Because then maybe, maybe I should have an ED instead of an ASC, right? Maybe I should put some dry powder into making an ED, owning an ED, and offering cath lab procedures in an ED basis so that I can go throughout a network insurance rates. Anyway, I, w- I, I'm having a hard time just trying to thread the needle between where we're at right now and how it is that you build your contract with the hospital. That's what I wanted to kind of land on. And we're absolutely definitely going to have to talk to you more because we've already consumed 1 hour and it's just there's so much more to dissect. But give me at least a high level, if you don't mind sharing, the nature of the contract with the hospital, unless it's proprietary and you don't want to share, that's fine. The idea is you essentially sell the hospital a service line and you negotiate a rate, but they do everything.
They keep everything. Yeah. And the purpose of that is to avoid Stark law violation.
And the amount of money cannot be subject to any productivity because of Stark law.
Yeah.
So you essentially negotiate a round number. Let's say, you're like, hey, we're going to be here and you guys pay us $1,000 a year. And that's it. And rain or shine, you're going to get $1,000 a year.
Yep. That's it. That's it.
How often do you renegotiate?
We like to get 3 to 5 year contracts. So we're not doing the year-to-year contract. It's, we just can't live with that kind of volatility. But fact of the matter is, again, with physician shortage, it's like, who's going to come in, but at the same time, just for stability, 3 years. And it also, look, it's not just us, it benefits them, because if not every year we could just be increasing for inflation and cost of living. And when we renegotiate, definitely those would be taken into account. But yeah, 3 to 5 years is a good sweet spot.
Yeah, I have like a million questions on this
Yeah.
topic.
Yeah, sure. If you're to open an
Can
ED,
we have
and
you and your dad? I know your dad's been a great influence and
yeah, I would love to
has
have him on. His answer to that was, we can talk about it. The old man is old.
you have to answer back. Great, awesome. I already put us on for the next one.
Yeah,
just don't
exactly.
even
Yeah.
just like, okay, great. That means that you're on. You're in.
Yeah.
That's what I would do to
Yeah.
my dad.
I have heard rumor of some OBL operators that are out there that when in negotiation, or when they don't get the rate they want with a commercial payer, they'll continue seeing patients, they'll bill out of network, and then they'll actually spend the time and money. The problem with as an OBL operator, right, is you don't have the capital to survive no income, right? Because what, if they end up having to pay you in 3 years, but the business is dead in one because you just can't hold out having no revenue in the amount of time, the war is still won. So it's not about paying, it's just business, right? So they'll just bleed you dry in the whole process of you getting lawyers and going to that review board and everything to get the money. And by the time you can actually collect the money, then the practice is dead anyway because you haven't had revenue. But I have heard of some OBL owners doing that and doing it successfully. But you've got to have capital. They maybe have other sources of income, which is they'll maybe do it one commercial payer at a time, so that at least their other contracts, or they're seeing plenty of Medicare, and so then their Medicare is paying, and they have something to bridge them through that process, right? Because it's very costly, but it is doable. The issue from a business standpoint of having that is, eventually your patients are going to realize they're going to an out of network, and they're going to get hit for larger out of pocket expenses, and it's going to push them towards going to an in-network facility. So while that does make sense, I think that the patients eventually will just end up going to an in-network place.
Not if they realize that you can't take them to collections.
Yeah, true.
Right. I mean,
Yeah,
you got a bill for the hospital. What if you decided not to pay the $1,000? They can't do shit.
Yeah. Well, they'll ruin my credit.
It's gonna become. No, it doesn't. Not healthcare. Healthcare doesn't ruin your credit.
Yeah, they send you to a collections agency, and then they report it on your credit.
Not if you don't, is what I'm saying.
Oh, yeah. If you
like
don't,
if I say,
yeah, if you choose to not do that.
Exactly. And that's the thing is, if your company decides that they're not going to send people to collections, then we live off of the actual true collections from the insurance companies, which if we can do out of network, we actually have more than we should. So we don't really need your higher copays.
So I believe that when you look at private insurance, though, it's actually a contractual thing that you are to be charging the patient that, right? And then how you follow up on it or enforce it is up to you. But with CMS, it becomes illegal, because if there's the copay, So let's say the copay is 20%. So again, just using round numbers, let's say it's $1,000. CMS pays $800, and you should charge the patient $200 copay. And the agreement is an 80-20%. If you don't charge the copay, then what CMS should be paying is 80% of the $800, not the $1,000. And that's where the legality becomes. That's the legality. That's where you can get in trouble, right? So essentially, if you don't want to charge a copay, then it should be 80% of 800. You charge
Eric,
it, you just don't
charge
follow
it.
up. Yeah.
You don't collect it. Exactly.
Yeah.
That's what I'm saying. Like,
yeah.
I mean, I'll bill you. You'll get an invoice.
And if the
But
patient
you're
doesn't pay it,
going to
then
have
you
a
just
call.
say,
if you paid, you paid. If you don't pay it, c'est la vie.
Yeah.
And with c'est la vie, we finish this podcast, guys.
Look at this. C'est la vie. C'est la vie, c'est fini. How about that? I like that.
C'est fini.
All right.
Yeah, this is not, as I learned, I was just in Paris last week. I just learned the business stuff. It's not intuitive. It's not intuitive.
It's not intuitive.
Intuitive.
All right, guys. This was awesome. Thank you, guys. And we will definitely do another one with Eric.
Yeah, I'm going to just draw a big X on this.
I want to get Eric Sr. Question before we go. How many of your notes percentage-wise did we get through? 10%, 20%, 60%?
Maybe
hopefully
20.
less than 5. Oh,
20.
Okay,
we did, but it was more of like a
20%.
It was more like a Rorschach than it was an outline.
We succeeded.
Oh, we succeeded.
I like it.
We were aiming for 50% or below.
No, yeah, definitely. We were under 50%. But, I think what we do is we do a couple episodes of this, and hopefully people start to understand, a little bit of the business, and then can use this too. As I say, I think we're looking at a new age in medicine. And if we as physicians can actually be courageous and advocate for ourselves, we can negotiate good contracts, be independent, and there's no reason that healthcare systems can't pay more money for these contracts. They can afford it.
Viva la revolution.
Exactly.
LOF.
Viva la resistance.
La resistance.
LOF.
All right, guys. Vamos.